Hello and good evening, everyone. Welcome to our 79th Blueheads virtual seminar. Blueheads virtual seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blueheads Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Mohamed, a general physician and first aid trainer from Blueheads Ethiopia. Today, it's a pleasure of having Dr. Alexander Mohamed with us to have a seminar on family planning. So Dr. Alexander Mohamed is an assistant professor of obstetrics and gynecology, and he has several years of experience in the field and is currently working at Cadisco General Hospital. So Dr. Alexander, the stage is all yours. You can begin.
Thank you, Dr. Eno. So today will be, good evening everybody. Nice to have you here. Today we'll be discussing about family planning. Family planning, we cannot overemphasize the benefits of family planning. It has far-reaching implications both for the family and for the society and the country as a whole. So if we take this topic, we can have a whole seminar about it, so we won't go deep into it. Before we start out today's discussion, let me give you one case. So this is a actual event that happened to me. A young woman came in her 20s to the OPD asking for contraception. She's on her 13 days of cycle. She was not sexually active for the last 2 years, and she went to his OSP because she's planning to have intercourse starting today. So, what will you recommend her? What will you give her? This patient went to the health center initially. So we will be talking about the case further, but I want you to think about this case when we continue. So the first question is contraception safe? This is a very question that comes again and again in every OPD visit. Most patients are very concerned about safety of contraception. They, especially when the contraception fails and they become pregnant while taking contraception, they are also worried that this might cause a problem to the baby. And also the side effect of the contraception, they are very afraid of this side effect. And for this fear, a lot of people avoid using contraception. So the first question, the first thing you have to discuss about risk versus benefit. When you talk about contraception, is it something risky? So there is a table that we'll be seeing in the next page. So which is safer, using contraception or not using? In this table, you can see the birth-related diseases or method-related diseases in different contraception. You can see in pregnancy, in the healthy young age group between 15 and 24, 5 women die out of 100,000 in the US because of the pregnancy-related complications. If you can see abortion, only 2 people die because of this abortion-related complication among 100,000 women. And if you can see the contraceptives, they are much safer than pregnancy. So whenever we think side effect or dangers of contraception, we should always tell the patient that this is much safer than the abortion and much safer than having pregnancy. If she is pregnant, she is 5 or 6 times more likely to die than using contraception. So we can say they are very safe. There is still a big unmet need of contraception in our country. If you see in the US, half of pregnancies of all pregnancies in the US, half are unintended, and among this half of them are because of failed contraception. While using contraception, they failed. In Ethiopia, the proportion of women in reproductive age group who have met their modern need of contraception is improved significantly in the last 20 years. Currently, it is around 62.6% who have met their need. So you can see the table here, the graph. Our contraception, the unmet need of contraception has significantly dropped in the last 20 years. And compared to the Africa or compared even to the world, our graph is very steep. And here you can see the proportion of different methods. The most, as you can see, the most common method used in Ethiopia is injectables, followed by implants. So, in contraception, there are different classifications. There are different ways to classify contraception, and one way of using classification is using their effectiveness. This is especially important for my practice when I speak to clients. Classifying contraceptions by their effectiveness is very important. It helps the mother or the woman decide which contraception to choose. So using this classification, we have the first class is the most effective, second class is very effective, third is effective, and the last one is the least effective contraceptions. So when we advise patients, having this classification in her mind will really help her to choose which one to use. Still, we can use the other classifications where we classify them into hormonal, barrier, and IUCDs, but classifying as the effectiveness will help the woman decide easily. Here we can see the different failure rates of different contraceptions. As you can see, the most effective, the ones on top have the least failure rate. Then as we go down the table, it goes up. And finally, on the last two lines, with the withdrawal, it's not classified as any of them. And some experts even do not consider this as a form of contraception. So the other thing before we go to the classifications is that we have discussed about medical eligibility criteria. It's a criteria where we try to decide which contraception to give to the woman. It's classified into four, 1, 2, 3, 4, and number one would be there will be no restriction to use the method. Number two would be the advantage usually outweighs the risk, so we can easily use it. And method three, the risk outweighs the advantage, and we usually avoid it unless if we don't have option, we usually avoid it. And if the category is number four, we totally avoid that mode of contraception. So you can download these apps in your phone. They're very helpful to decide whether to give a contraception to women or not. You might not remember every detail, so having this app in your phone will help us decide with the mother which contraception to choose. This is again the table for the WHO. Each category is either 1, 2, 3, 4. You can see in this table. So first, let's discuss about lactation. Approximately 20% of breastfeeding women will ovulate by 3rd month of postpartum, and ovulation often precedes menstruation. So before she starts menstruation, she will have ovulation. In Ethiopia, again, most women believe it's not possible to get pregnant without seeing menstruation. So the fact that she has seen menstruation means she already ovulated once, and the ovum did not get any sperm, so she had the menses. And of available methods, copper is in breastfeeding women has category 1 or 2 rating, so it's one of the copper IUD is one of the best. And also the progesterone only pill have little effect on lactation. They are also preferred by some for the first 6 months in women who are exclusive breastfeeding. And both progesterone only pill and depot injection may be initiated prior to discharge while she's in the hospital. After delivery, we can start her and discharge her. For estrogen implant insertion is delayed until 4 weeks postpartum, or those if they are exclusive breastfeeding, that can be inserted anytime for those who are not nursing. And combined hormone contraceptive may begin at 6 weeks following delivery. If breastfeeding is well established and infant nutrition is good, we can start at 6 weeks. Previously, it used to be at 6 months, but now they have decreased it to 6 weeks. So, what are the top tier, the most effective ones? They are intrauterine contraception is the first. Intrauterine contraception is not as prevalent in Ethiopia as in other countries. For example, in Ethiopia, only 2% of women use the IUCDs. In the US, it has increased in the last few years from 2 to 10, but the world average is around 14%. And if you go to China, 40% of women use IUCD, which is very high number. So the first one is the living sterile circulating entertainment systems. There are two types. The copper is one that is mostly available in Ethiopia. And the second one is the hormonal one. The most common among these, the hormonal one, is the brand name Mirena. There are other two also approved by America, but they are less common and they also take shorter years. They are usually for 3 years. Mirena works approved for 5 years, and mechanism of Mirena is it renders the endometrium atrophic. It stimulates thick cervical mucus that blocks the sperm penetration and decreases tubal motility. And also, the progesterone might also inhibit ovulation, but this is not consistently present. In most progesterone-containing contraceptions, ovulation is not the main method of preventing pregnancy. When you go to the copper one, the number 380 is because of the surface area in millimeters square. The body has 314, and each arm has 33 millimeters square of copper. In total, it becomes 380. The copper 380 is approved for 10 years, even though studies have shown can function up to 20 years, but the approval is for 10 years. The mechanism is it causes intense local inflammation response induced in the uterus by the copper. It leads to lysosomal activation and other inflammatory actions that are spermicidal, so the sperms will not pass. In the unlikely event that fertilization occur, the same inflammatory actions direct against the blastocyst, and finally the endometrium becomes hostile for the implantation. So the blastocyst will not implant in the uterus. This is a picture where you can see a dime and the copper and the Mirena IUCDs. These are the contraindications for both for the copper IUCD and for Mirena. We will talk a little detail about them. So counseling is very important in IUCD because it's one of the most misunderstood method of contraception. Most people have a very high negative feeling about it, and they do not want to use it. During the modern renaissance of IUCD, several improvements have resulted in safer and more effective methods. There are still some unwanted side effects, and as I mentioned before, there is strong misconception about IUCD. With current device, insertion generally does not increase the risk of infection. In previous studies, the risk of infection was a bit higher, but currently the risk is very minimal. And especially if infection occurs 45 to 60 days after insertion, it's not caused by the IUCD. We assume it is caused by a new infection, a new STI, but they might have infection during insertion. Otherwise, after 45 days, if you have a pelvic infection, this is not caused by the insertion. And again, previously, many porous IUD candidates were previously precluded from IUC use because of, again, the fears of compression, the fear of infection induced sterility was a concern, but now that risk is low. So we can also insert IUDs in nulliparous young adolescent women. Again, HIV, sorry. In HIV-infected women, intrauterine contraception is appropriate or there's no specific contraindication for IUD use. Previously, again, HIV was a field because the risk of infection was higher, but now HIV infection is not prevented the use of IUCDs. We can have a post-abortion or postpartum placement is possible. There are 3 times to insert IUD. One, you can insert it after abortion. The second, you can insert it after delivery, immediately after delivery, or even during cesarean section, you can insert it. And the third one is the interval insertion, which is 6 weeks after delivery. Commonly, IUDs may be associated with change in the menstrual pattern, and this change in the amount of bleeding and the pain during bleeding can be treated by non-steroidal anti-inflammatory drugs, but these non-steroidal anti-inflammatory drugs will diminish both the amount of bleeding and the pain during menstruation. With the medicated IUCDs, women are counseled to expect irregular spotting up to 6 months. after insertion. And thereafter, they expect monthly menses to be lighter and even absent. So the Mirena can cause amenorrhea. And also it is a very good medication for AUBs also. You can give it for AUB and it can control the AUB. There is slight risk of expulsion and even slight risk of perforation. So approximately 5% of men spontaneously expel their IUCD, and this is most likely during the first months. So usually after insertion, after 1 month, we appoint them. Especially after 1 month after insertion, we wait for 1 menses, and after the next menses, we evaluate her for the placement of the IUD. We can do ultrasound and see whether it is in the normal place or not. When you come to ectopic pregnancy, there is a misunderstanding about ectopic pregnancy in contraception. Because when we learned in medicine, we can remember that contraceptions are a risk factor for ectopic. But this is a misnomer. Actually, is a or other contraceptions are effective in preventing all pregnancies, but they are especially more prevent intrauterine pregnancy. They still prevent ectopic pregnancy, and ectopic pregnancy rate is lower in those women using contraceptions. So we can, in short, say any contraception is not a risk factor for ectopic pregnancy. But if the woman gets pregnant while using contraception, then the likelihood of this pregnancy being ectopic is higher. So as a whole, for the patient, the risk of ectopic decreases if she's using contraception methods. So as this I have already mentioned, the timing of insertion can be postpartum, it can be post-abortion, or it can be interval. But insertion is not limited to this time. We prefer this time, the interval, to be after the menstruation, which is where the cervix is softer and easier insertion. But we can insert IUCD at any time of the cycle if we know she's not pregnant. In this case, we can see the first, when we start this session, the first case we have seen is the woman with 20 years old woman who came to the clinic. She initially went to the health center. She asked for contraception. They told her to come back when her menstruation comes. She went, but she got pregnant in the meanwhile. And she came for an abortion. She induced abortion. So this one, if IUCD was inserted at the start, she would have had to have induced abortion. So the next one is the progesterone implants. Contraception can be provided by the progesterone-containing device that is implanted subdermally, and it releases hormone over many years. There are different types. The one mostly available in Ethiopia, previously Jadel used to be more available. It works for 5 years. And the second one most available will be the Norplant, which is available it works for 3 years. The next plan also, it works for 3 years. The mechanism for this contraception is they suppress ovulation, they increase cervical mucus viscosity, and they induce endometrial atrophy. The contraindications would be pregnancy, thrombosis or thromboembolic disorder, benign or malignant hepatic tumor, active liver disease, undiagnosed abnormal vaginal bleeding, and breast cancers are the contraindications. So when we counsel for these contraceptions, we should strongly tell them that they can cause irregular bleeding that does not normalize over time. So if we advise this and the woman is aware, and if this complication occurs, it will be easier for her to accept this fact. So if a woman who cannot tolerate this unpredictable and irregular spotting or bleeding should not start this contraception from the beginning. If we found this implant to be not palpable during physical examination, it can be imaged by radiography, it can be imaged by CT scan, ultrasound, or an MRI. Norplant and Jadel are radio-opaque, which means they can be easily seen by X-ray. They are very clearly seen. But Implanon is not radio-opaque, so you cannot easily see it with X-ray, but rather we will do ultrasound or MRI. The next most effective contraception is the permanent ones. In 2011 to 13, surgical sterilization was one of the most commonly reported forms of contraception in the US. Among these contraception, again, the female tubal sterilization is more common. This is usually accomplished by occlusion or division of the fallopian tubes to prevent ovum passage for fertilization. And 27% of contraceptive use in the USA was because of this tubal ligation. There are generally three methods that we can use. One can be application of various permanent rings or clips to the fallopian tube. The other one would be electrocauterization, and the third one would be ligation with social material. In Ethiopia, the third one is the more commonly available one, and that's the one that we use mostly. So, in the permanent one, because it is irreversible, there is the possibility of regret. There will be some people who regret it. So, initially, strong advice is very good. Counseling is a paramount important. We should counsel her strongly, and it should not be decided in labor. Rather, we should advise, and the decision should be before labor during the ANC. For me, if a woman decides to use permanent contraception during labor, I usually decline to do it because they are emotionally unstable. Their decisions might not be the right one at that time. Again, any contraception has method failure. Again, this is a fact that most parents do not know. They think if they are using contraception, there's no way to get pregnant. But every contraception can fail, and just the numbers are different. So how can the permanent ones fail? The first is the surgical error, the most common one. It accounts to 30 to 50% of the failure rates. The second is the tubal fistula may complicate the occlusion method. In some cases, sterilization failure may follow spontaneous reanastomosis of the tubal segment. And the last one would be there might be a luteal phased pregnancy where she was already pregnant at the time of the procedure, but she does not know that she was pregnant. And even if you do a HCG test, it will be negative during this time. There are other methods of doing this sterilization. One is the trans-cervical one. There are two options, either using mechanical ones or chemical ones. But when we use the chemical ones, we should when we use the mechanical ones, we should confirm that the tube were blocked after 3 months by using hysterosalpingography. And after this confirmation, we allow her to have intercourse without using other method. So after making mechanical tubal occlusion using the trans-cervical method, for 3 months, she should use another contraceptive method. And the chemical tubal occlusion is not recommended by the WHO because of the risk of cancerogen. The other sterilization is the male sterilization, which we call vasectomy. In US, around 500,000 people do it. It's less common than the female one. And it's an office procedure. It's done with local anesthesia and usually takes less than 20 minutes. Compared to the female sterilization, vasectomy is 30 times less likely to fail and 20 times less likely to have postoperative complications. So it is much safer than the female sterilization. So we should promote this one more than rather than the female sterilization. Sterility following vasectomy is not immediate. So sterility is achieved after 3 months of the procedure or after 20 ejaculations. So another form of contraception should be used until you can confirm azoospermia. And to confirm azoospermia, the recommendation is to do 2 consecutive sperm counts with 0 sperm. Then we can tell the mother that she can stop using the second method that she was using. So now we go to the second tier contraceptive methods. They are a little bit less effective than the first ones, but the reason for this failure is usually because these second tier methods are mostly dependent on the client's how should I put it? if the patient forgets to take, for example, the injection, or if the patient forgets to take the pills, then the likelihood of pregnancy increases. So if in ideal use, they are very effective, but we are not living in an ideal world. So people tend to forget, and this will increase the risk of pregnancy. So they are considered very effective, and there are hormone-containing preparations like the combined oral contraception, progesterone-only pill, or contraceptive with estrogen or progesterone that are made systemically available by injection or transdermal patch or transvaginal ring. When used as intended, this method is highly effective, as I mentioned. First, we will see the combined one, combined hormonal contraceptive. These are contraceptives that contain estrogen and progesterone. There are three formats. One is the oral contraceptive pill. The second one is the transdermal patch. The third one is the transvaginal contraceptive ring. Because of the limited data about the second two, we mostly talk about the oral contraceptive pills. These are, again, some of the side effects. I mean, the contraindications to use the COC, but we will discuss further in detail in the next few slides. So the mechanism is, the most important is to inhibit ovulation by suppression of the hypothalamic gonadotropin-releasing hormone, which prevents lethal secretion of FSH and LH. And the estrogen suppresses the FSH release and stabilizes the endometrium to prevent intermenstrual bleeding. The progestins inhibit ovulation by suppressing LH. They thicken the cervical mucus to retard sperm passage, and they render the endometrium unfavorable for implantation. Currently, the daily dose of the estrogen decreased significantly. Previously, it was around 50, but now most pills contain around 35 micrograms. But there are pills with lower 20, even then recently there are pills that come with content of 10 microgram. But the mostly available ones is the one with 35 microgram. With the combined contraception, the progesterone doesn't the progesterone dose can be constant throughout the cycle, which is what we call the monophasic pills. But the dose can also be varied. We can change the dose. We can have the biphasic ones, we can have the triphasic ones, where they have 2 or 3 different doses for in the 1 month. So when should we start the pills? Ideally, one would begin the pills on the first day of menstruation. This is the ideal one. There is a more traditional method where they use the Sunday start method, where we start on the Sundays. This increases patient adherence to the pills, but it has risk of having pregnancy before she starts the pill. And the quick start is when we start the pill on the day she came. Again, we can see the case we have discussed previously, the case 1, where the woman could be started on the first day of whatever day she came. We can start on that day. But both with the Sunday start and the quick start, we have to have another method of contraception, usually a barrel method, for the first 1 week. But after 1 week, this COC can be effective and she can take them. She doesn't have to necessarily wait for menstruation. But when we came to practice in Ethiopia, when you go to most health centers, nobody will give any contraception unless they see a menstruation, which is a very wrong approach. So if we miss a pill, what happens? So during the COC, if one dose is missed, conception is unlikely, especially with the higher dose. With the 35 microgram, it's unlikely. So what we do is, on the next day, we start to take a double pill and we continue with the remaining tablets. If several doses are missed, or if a dose is missed with the lower dose ones, with the biphasic or the triphasic ones, then 2 pills are taken, but an effective barrier method should be used for the next 7 days. The other option would be to discard that strip and start a new one, but still using a barrier method for 7 days. One thing you should always remember, combined oral contraception, or for that matter, any method of contraception is not teratogenic. If a woman got pregnant while taking the pills, there is no problem. She can continue the pregnancy. There is one type of combined oral contraception called the extended cycle contraception. This package formulations are available with extended cycles, where there are tablets with 90 tablets, where 85 of them are active estrogen and progesterone containing pills, and the last 5 would be iron containing. If you don't have this package, for example, in Ethiopia, this is not available. You can still use the normal COC. You can take the 21 active tablets and discard the 7 iron containing inactive placebo pills, then continue the next cycle. You can do this for 3 consecutive months. If you are using the transdermal patch or the vaginal ring, you can just skip the 1-week hormone-free interval. So, with my practice in Ethiopia, there are women who require this, especially those who are planning to go on a trip, or they are planning to have a meeting or a conference, and they don't want to have this menstruation. Or sometimes, or in Muslim women who want to fast the whole month, they would like to avoid having menstruation during this month. So what we advise them to do is to take, as I mentioned, only the active tablets. And when she wants to get pregnant, when she wants to have her menstruation, she can just start inactive tablets, taking the placebo pills. There's several factors unique to this extended cycle combined oral contraception. Some of these are shared with the continuous progesterone contraception methods like implant or injectables. The principal change is the loss of menstrual normality that manifests as less frequent, lighter, and generate unpredictable bleeding episodes. There's decreased risk of endometrial malignancy in this one compared to the normal COC, and continuous combined oral hormone contraception methods report fewer menstrual symptoms that include headache, fatigue, bloating, and dysmenorrhea compared with the woman using the cyclic contraception. These are different preparations available. These are some of the drugs that might affect the dose of the contraception, and these are some of the drugs that may reduce combined oral contraception. These drugs reduce the dose of combined oral contraception, and there are also non-contraceptive benefits of COC. About this one, we'll talk a little bit further. There are few drugs that affect the dose of that makes the COC less efficient. These are the tables showing non-contraceptive benefits of COC. Again, I won't go to the detail. Combined oral contraception and medical disorders. So, in obese and overweight women, CHCs can be highly effective in obese women. However, obesity may result altered pharmacokinetics of some CHC methods, and excessive weight gain is a concern with use with any hormonal contraception. So, for combined hormonal contraception, obesity and overweight is category 2. When it comes to diabetes mellitus, high dose of COC were previously associated with insulin antagonistic properties, particularly those with progestin. However, with current low dose COCs, this concern has been mitigated. And the use of this contraceptive is approved for non-smoking diabetic women who are younger than 35 years and have no vascular disease. So for them, for most women, diabetic mellitus is category 2 for all hormonal. For IUD, it's category 1, but diabetes is category 2 for all hormonal contraceptions. When it comes to cardiovascular disease, in general, severe cardiovascular disorders limit the use of combined oral contraception. For less severe disorders, however, current formulations do not increase risk. And usually we advise all women taking the combined oral contraception to return after 8 to 12 weeks for evaluation of BP and other symptoms. For those with already established chronic hypertension, COC's use is permissible in those with well-controlled BP. Otherwise, we should avoid it. In severe forms of hypertension, especially those with end organ involvement, they should avoid using COCs. Women who have had documented myocardial infarction should not be given COC. But you should keep in mind that COCs do not increase de novo risk for MI in non-smoking young women. The risk is always in those with multiple risk factors. When you come to cerebrovascular disorder, women who have had either an ischemic or hemorrhagic stroke should not use COC. But the incidence of stroke in non-smoking young women is low, and the use of COC does not increase the risk for either type of stroke. This form of vascular disorder is more commonly encountered in those who smoke, have hypertension, or have migraine headache with visual aura and who use COC. So as I mentioned, when they have combined risk, they are highly likely to develop complications. For many of these women, an IUCD or progesterone-only pill may be more appropriate than using the COC. When you come to venous thromboembolism, these risks were found to be estrogen dose related and have been appropriately lowered with evolution of the low dose formulations. As I mentioned previously, it used to be 50 microgram. At this dose, they were more common, but when you decrease the dose of estrogen, the risk of venous thromboembolism decreases. But you should keep in mind, the incidence of venous thromboembolism is only 3 to 4% in 10,000 women. But if this woman does not use COC and she gets pregnant, the risk almost doubles to 5 to 6 in 10,000 woman years. So again, as I mentioned initially, contraceptions are safer than the alternative. The alternative being having an abortion or having pregnancy. There is a 2 times increased risk for perioperative venous thromboembolism in COC use, but this two times increased risk is for the previous higher doses. But the current low dose, there's no data to recommend decreasing COC before operation. But still, they have not removed the recommendation. The recommendation is still there. So we recommend stopping the COC 4 to 6 weeks before the surgery to decrease the risk of thromboembolic effect, because surgery also has increased risk of thromboembolic effect. Again, since SLE in the past it was contraindicated because of the higher risk of venous and arterial thrombosis. Now the risk is lower, but we should avoid COCs in those with SLE plus with positive testing for antiphospholipid antibody or have known contraindications for the CHC use. The affected women with these antibodies have increased risk of clotting, so that's why we avoid COCs. When it comes to seizure, the metabolism and clearance of some combined contraceptives are appropriately altered by some, but not all anticonvulsants. So, one mechanism is with several antiepileptic drugs is the potent inducers of cytochrome P450 enzyme system, which this enzyme increased, the level of the hormone in the bloodstream drops, and the effectiveness of the contraception is lost. So, it's category 3 for COC and POP, it's category 2 for depot and implant, and category 1 for both type of IUCDs. When it comes to liver disease, both estrogen and progesterone have known effect on hepatic function. Cholestasis and cholestatic jaundice, which is more common in pregnancy, is also increased in people who are using COCs. Women with viral hepatitis or cirrhosis. For women who have active hepatitis, COC should not be started, but may be continued for women who experience a flare. If she was already using a COC, she can continue. Use of POP in this woman is not restricted. So in hepatitis or cirrhosis, she can use POP. With cirrhosis and with mild compensated disease, does not limit the use of both, but severe decompensated disease, in this case, all hormones should be avoided. When you come to neoplastic disease, sex steroids have this stimulatory effect on some cancers, and this is a concern. These hormones do not cause cancer by themselves. They are even protective effect of for cancer for endometrial and ovarian cancers. But hepatic foranodular hyperplasia and benign hepatic adenomas were previously linked with higher with all the higher dose of COCs. However, studies that evaluated women taking the current low dose, no association has been found. Similarly, earlier correlation between COCs and hepatocellular carcinoma have been refuted currently. And for women with known tumors, COC may be used in those with focal nodular hyperplasia, but avoided in those with benign hepatic adenoma and hepatocellular carcinoma. Cervical dysplasia and cervical cancer rate are also increased in COC, but they don't know the reason. They have speculations on what might be the cause. One of the speculations is because of women taking COC, they are not using barrier method. They are not using condom. So they are at high risk of having HPV infection. And because of this woman with COC have more follow-up in the gynecologic, they are more frequently to have cytologic screening, so which means increase the number of detection. They also may increase persistence of HPV infection and HPV oncogenic expression. All these are speculations and none of them have been proven. In breast cancer is stimulated by female sex steroid hormones, but it is still unclear whether the COCs have adverse effect on tumor growth or development. The second type of oral contraception is the progesterone-only contraception. This type of contraception that contain only progesterone were developed to obviate the unnecessary side effects of estrogen. As I mentioned, the COC have both estrogen and progesterone, and some of the side effects is because of estrogen, and some of the side effects is because of progesterone. So, having only progesterone will avoid the risk of the estrogen side effects. Progestins can be delivered by several routes that include tablet, injections, intrauterine devices, or subdermal implants. Among these progesterone only containing contraception, the POP, they do not reliably inhibit ovulation, but instead thicken cervical mucus and desexualize and atrophy the endometrium. Because mucus changes do not persist beyond 24 hours in POP, a pill is ideally taken at the same time, daily. Their use has not been achieved widespread popularity because of a much higher incidence of irregular bleeding and slightly higher pregnancy rate than that of the regular COCs. POPs have minimal, if any, effect on carbohydrate metabolism and coagulation actions. They have no effect. They do not cause exacerbated hypertension, and this may be ideal for someone at increased risk or other cardiovascular complications. Such women include those with a history of thrombosis or migraine headache, or smokers older than 35 years. We can recommend them to have POP. Because they do not impair milk productions, POP are suitable for lactating women as well. When used in combination with breastfeeding, POPs are virtually 100% effective for the first 6 months. There are some contraindications. If there's unexplained vaginal uterine bleeding, breast cancer, hepatic neoplasm, pregnancy, and active severe liver disease are the contraindications. Compliance is essential for POP. If a pill is taken even 4 hours later than the usual time, additional form of contraception must be used for the next 48 hours. When it comes to the injectable ones, injectable progesterones have mechanisms of action similar to those for oral progestins and include increased cervical mucus viscosity, creation of an endometrial unfavorable for implantation, and unpredictable ovulation suppression. Injectable preparations include the medroxyprogesterone acetate, which we what we call Depot. It's marketed as Depot Provera, and it's now available in our country. It's a 150 milligram dose, and it's given intramuscular injection every 3 months. Injectable progesterones have contraceptive efficacy equivalent or better than the COCs. They are more efficacious. And this injectable progesterones is the most commonly used in Ethiopia. The contraindications are women with pregnancy, unexplained uterine bleeding, breast cancer, active or history of thromboembolic disease, cerebrovascular disease, and significant liver disease. The potential effect and side effect: the DEPO usually causes irregular menstrual bleeding, and prolonged ovulation suppression may also persist after DEPO is stopped. So, 1/4 of women may not resume regular menstruation for up to a year. Accordingly, DEPO may not be the best choice for women who plan to use contraception only for a short time. Again, in Ethiopia, I see a lot of women who want to prevent pregnancy for 3 months, they taking DEPO because it works for 3 months. But you should not advise them to use for this kind of short plan. Rather, I prefer if this woman takes pills or barrier methods rather than having DEPO, which might prolong her planned pregnancy time. Bone marrow listening can also be significantly diminished because of the lower estrogen level, and it's most worrisome in long-term users, especially adolescents who have not achieved their maximum bone density level, and the perimenopausal women who are also at risk for osteoporosis. Concern of bone density should not prevent or limit use of a contraceptive method. Even though it's a risk, it should not make our decision changed. Weight gain is also another problem with the DEPO. When we come to the third tier of mechanisms, third tier contraceptive methods, like the barrier methods, the male condom, female condom, diaphragm with the spermicide or cervical cap, and the fertility awareness methods, they are less effective. Among the barriers, we should discuss a little bit about the male condom, which is one of the, the others are not available in our country, so male condom is available, and it's the only barrier method available in our country. And in addition to pregnancy prevention, it has STI prevention or also HIV prevention, which should be emphasized during our counseling with the patient. Otherwise, they are less effective than the others, and they are not a very good method for a long-term contraception method. And I won't go any further about them in detail. The fourth tier contraception method is the spermicide and the contraceptive sponge. And when you come to the emergency contraception, the methods currently available are sex steroid containing compounds, antiprogesterone compounds, or copper containing IUDs. Because duration of use is short, woman is condition that might normally contraindicate use of these drugs might use this one because she's using only for a short time. So even despite having contraindications, she might still prescribe them. These are some of the available formulations in our country. In the US. But among these, in our country, the one most available is the Plan B 1 Step 1, which is a 150 milligram levodopa, which is taken as a single dose contraception. So the mechanism of action is the hormone contraceptives have different mechanisms of action depending on which day of the menstruation cycle she took it, which day of the menstruation cycle the intercourse occurred. The major method is delay of ovulation. There are also endometrial changes that prevent implantation and interference with sperm transport or penetration and impaired corpus luteum function. Despite these effects, every method used for postcoital contraception will have failures. The failure rate is high. Compared to other contraceptions, the failure rate is the emergency contraception is higher. Pregnancies that develop despite emergency contraception appear unaffected by this method. So if pregnancy occurs, there is no contraindication to continue. In our country, people tending to use this emergency pill more commonly than they should. I face sometimes women taking the emergency pill 3 or 4 times per month, which is wrong. Except perhaps the copper IUD, other emergency contraception methods generally will not prevent pregnancy resulting from subsequent episodes of sex. They can prevent for one intercourse, but having 2, 3, 4 times in 1 month, they will not prevent. The only one that can prevent for subsequent intercourse is if you have inserted the copper IUD. Accordingly, use of barrier technique is recommended until the next menses. So, these emergency methods are made for emergency only. In case a woman have, let's say she was raped, or she had unplanned intercourse, that's the only time she should use pill. Even in unplanned intercourse, we advise them to use condom rather than post pill. Using post pill repeatedly is not advisable. So the pills should be taken within 72 hours, but maybe given up to 120 hours, they might be still effective. Even though the effectiveness will start decreasing, but the advice is to give within 72 hours. The progesterone-only regimens are more effective than the combined ones. The other method also, sometimes we might not find these emergency pills available in our setup. So in this case, we can use the normal POP or the normal combined oral contraceptions. So if you don't have the emergency preparation, we can use 4 to 5 tablets from the normal COC taken 2 times, or we can use, if you have only the POP, we can use 50 tablets at the same time from the POP to get enough dose to prevent the pregnancy. So the POP contains 0.03 milligram of levonorgestrel. So as you can see here, the plan B one step contains 150 milligram of levonorgestrel. So if you make the calculations, it will come to 50 tablets. So if you take 50 tablets of POP, you can assume that you have taken the emergency pill. The other method available is the anti-progesterone ones, or the progesterone receptor modulators. They have contraceptive activity because they prevent progesterone-mediated endometrial preparation for implantation. The most common one is the mifepristone. It's a progesterone antagonist. It either delay ovulation or impairs secretory endometrium development. You can use a mifepristone in a single dose of 25 or 50 milligram, and it is superior to the hormonal emergency contraceptions. The problem is mifepristone is not used for emergency contraception in most countries because of its high cost, and manufacturers don't produce this 25 to 50 milligram of mifepristone, not available. The third and last option for the emergency contraception is the copper-containing implantation device. It can be used up to 5 days after coitus. A second advantage is that this method also puts in place an effective 10-year method of contraception for the woman. These are my reference, and thank you.
All right. Yeah, thank you very much, Doctor. It was a very nice and clear presentation. So we can move on to the question and answer section. So if you can access the chat box, we can start addressing some of the questions that the participants wrote.
Okay. There's one question saying, people believe that IFCD causes ectopic pregnancy. To this statement, I will add not only people, health professionals, medical doctors I have seen advising patients that IFCDs and post pills causing ectopic. As I mentioned, they do not cause ectopic pregnancy. Let us do a simple math. Let's assume in Addis Ababa there are 5 million, let's say there are 1 million fertile young women. Let's make this calculation. There are 1 million women. So, among these 1 million women, if there is no contraceptive use and all 1 million get pregnant, the incidence of ectopic pregnancy is 1% in our society. So, there will be around 10,000 ectopic pregnancies in that year. Okay. Now, let's assume we give IUCDs, the highest proportion of ectopic is found in Mirena, which is around 33%. Let's assume we give Mirena for everyone. This is the highest proportion, 33%. So, if we give Mirena, among these 1 million people, there will be only pregnancy failure is around 0.1, which is there will be 1,000 pregnancies in that year. Among these 1,000 pregnancies, 1/3 will be ectopic, so around 300. So if you take this, for this 1 million women, the risk of ectopic pregnancy decreased from 10,000 to 300. It is a significant decrease in the risk of ectopic. But if at all she is pregnant, when you come to our, she comes to our clinic or to our hostel while being pregnant, we immediately should rule out ectopic because the risk of ectopic in this Mirena is 33%, 1/3 are ectopic. So for the woman, ectopic risk significantly decreased. But for us as health professionals, even when we teach medical students, we teach them that ectopic, I mean ISDs or most contraceptions are risk factor for ectopic because the proportion is higher. Among those pregnant, the proportion is higher. So IUCDs, emergency pills do not cause ectopic. Rather, even they protect us against ectopic. But the problem is they protect us more against intrauterine pregnancies, but they protect us less against ectopic. So
Okay,
there's another question asking, what's the interval to check for azoospermia? So the recommended is after 3 months, if you are using only interval, after 3 months of vasectomy, we check for azoospermia. If there's no sperm, we repeat again second test, again no sperm, then we can declare the man to be azoospermic. Or other thing you can use is, you don't have to wait 3 months. If he had 20 ejaculations, again after 20 ejaculations, we can check the semiosis and say he's azoospermic. So there's another question which also I face repeatedly in our hostels. Is partner consent needed for mother to receive contraception? The answer is no. You don't need a partner consent. If, I mean, the woman is above 18 years, below 18 years, having sex in Ethiopia is considered a rape, so we won't consider that. But anybody who's above 18 years can make their own decision. She can't decide by herself. Even if the husband comes and says, do not give her this method, he has no right. It's her body, her decision. But when you come practically, we recommend them to discuss among themselves and to reach in a mutual understanding, a mutual decision. Rather than the woman decides and he divorces her, damage is more than the benefit. So yes, we don't need consent, but we advise the woman to discuss with her partner and have a mutual decision. But if she says no, I don't want to tell my partner, please do this for me, it's her right. We can do it. We can do even the BTL without his consent. We don't need even the other methods. So the other question is when switching between one method to other method. When we switch contraception from one method to other method, each method has its own specific needs. For example, if a woman using IUCD wants to change to hormonal, so if we remove IUCD on her 13th day, she can get pregnant the next day. So we assume she was not on hormonal, not on contraception, because the IUCD do not prevent ovulation. It has no effect on that. So removing in the middle would make her the risk of getting pregnant. So if she decides that, then we can remove it. And let's say she wants to have a depot or implant, we can still do that, but we need to this. She should use a barrier method for 1 week. If she removed IUCD on her first day of menstruation, then no problem, she can start any drug. On the reverse side, if she was on, let's say, depot, and she wants to use the IUCD, then the depot day did not pass, which means the woman was not ovulating, because mechanism of action depot is main of prevent ovulation. So as soon as she comes to our clinic and she wants the IUCD, the day we insert IUCD, it is effective. Even we can use it for emergency contraception after sex. So there's no waiting time, there's no need for other method, because as soon as we insert the IUCD, it's effective. So each method, when you change from one method to the next one, each method has its own method of prevention, and we should think of that. And if you are not sure, then it's better to do it on the first day of menstruation. So the next question is, a woman presenting with AUB who had an implant, is COC recommended? Yes. We give COC. We try to control the bleeding. Someone might come wanting removal. So what I do is I usually advise her to try with the COC. Usually the AOBs, they do not last. Mostly the AOB caused by the implant will subside by 6 months. By 3 to 6 months, they subside. So what I personally prefer is I try to control with COC. The COC will usually control, it will stop it. After I stopped it, again I stop the COC and check the mother. If she's still having AOB after the COC, then I might consider changing the method. But I wouldn't rush to change the method. It's her right if she wants to. It's her right. I cannot force her. But I would recommend her to use the COC for 3 months, then stop the COC and see. If AOB comes back again, then I will change the method. So the next question is, why is timing important for POPs? POPs, as I mentioned before, if we delay the POP by 4 hours, let's say she used to take the POP at 8 p.m. At this time, and that time she went out for a dinner or she had a wedding and she took it at midnight, then it is no longer effective. She should use barrier method for the next 48 hours because the protection is lost. The window is very narrow, so every day she should take it every day. Not only every day, she should take it the same time. If the delay is more than few hours, more than 4 hours, she should use barrier method for 48 hours. That's why the timing is very important in POPs. So next question is, what do you say about natural method if there is commitment by both partners? Again, contraception is her right. We cannot, let me tell you, most of the time what the patient asks us. So when they come, when we talk about contraception, the first question they ask us is safety. Is it safe? I have mentioned before, I have discussed about the safety. I will not discuss anymore, but the first question patients ask us is safety. They are very concerned about safety. And because of this fear of safety, that's why they usually want to use traditional method. If she understands that this natural method is less effective, and if she accepts the fact that she can get pregnant, and she's committed, yes, they can use it. It's their right. We can only, and also one more advice for everybody. We should not select contraception for them. They should make the choice. If there is only one option, then you cannot do anything about it. But we should let them choose among the available methods. If there are contraindications for her, we can remove that method from the list, but we give them a list and she chooses from that list. As I mentioned, natural method is less effective. So, like, if less effective, it means she can get pregnant. If she gets pregnant, she will either have a pregnancy or she'll have induced abortion. So, if she's okay with this fact, then she can use it. So, the next question is, can you elaborate more on when to start COC? We have 3 options. The one that is commonly used in Ethiopia is to start after the next menstruation. So if you go to the health center, they will tell you, come when menstruation comes, and they will start you on that day. The reason we do that is to make sure she's not pregnant. So if she's not pregnant, then she can start on the first day. Now, if you have seen our presentation from the beginning, the first case, the woman came, she was in her 20s, she wanted contraception. She wanted COC. She was on her 13th day of cycle. So, and she didn't have sex for the last 2 years. It means we know she's not pregnant. She had no sex for the last 2 years, she's not pregnant. So in this case, we can start the COC on the same day, but give her a barrier method like condom for the first 1 week. So she takes 1 week a barrier method while having the pills, COC, she uses condom the first week. On the second week, it will start to be effective and she can continue. So again, they have three methods. The easiest is the one with start on the first day of cycle. The second one is start on the first Sunday, which is not very common in Ethiopia. But the third one is to start on the day she came, provided that we know she's not pregnant. If this woman had sex 2 days ago and she comes to us, we cannot know she's pregnant. We cannot know, even if you do HCG will not be positive in the first 2 days. So in this woman who had sex 2 days ago and want to have contraception and she wants to start COC, in this case, I have to wait for the next menses. And meanwhile giving her condom until the next menses comes. Or at least wait for 7 days and do serum SG and then we can start also. That's also a possibility. But the point is, we should be sure she's not pregnant. In that case, we can start anytime. And when we start the tablet, have a barrel for 1 week. I think I'm clear, Dr. Mohamed. COC or POP missed. How can she take the next pill? POP, if missed even not for 1 day, for 4 hours, it's not effective. She should use a barrel method for 48 hours. COC missed, it depends on the dose of the estrogen. If it's high dose, the previously 50 microgram is not available. Currently we have the 30 microgram. If the 30 microgram COC that she's using, then the next day she doubles it. So today she missed 1 tablet, tomorrow she takes 2, and then she continues 1 after that. So let's say today is Thursday, she forgot Thursday, and on Friday she will take 2, on Saturday she will continue 1, Sunday 1. If she forgets more than 1 day, or if she forgets in a low estrogen containing COCs, in that case, even if she forgets for 1 day, she should use a barrel method for 1 week. Take the one she forgot she forgets for 2 days, we can make double for 2 days. And other option would be, this is a bit more confusing for the patient. So what I prefer usually, what I do is, she forgets more than 1, I discard the COC, start a new one, use condom for 1 week. So which one is available in Ethiopia? In Ethiopia, we almost exclusively have the 30 microgram COCs. So because of the 30 microgram COC, 1 day missing is no problem. But if she forgets for 2 days, then she has to start a new cycle and use the condom for 1 week. So a woman with ICD in situ and comes with a pregnancy. Lost IUCD, difficult for removal, and came with pregnancy. So let's first, what is your recommendation during and after current pregnancy on removal and choice of other method? Okay. So, woman who had IUCD got pregnant. What do you do? If the string can be located, it is accessible, we remove it. Because risk of abortion is around 50% for those who have IUCD in situ and 25% for the removal. So removal is safer. So we remove the IUCD and let the pregnancy continue. But this case, the one you are mentioning, the woman had lost IUCD. So the string is not accessible and she got pregnant. In this case, we can allow the pregnancy to continue. It has high risk of abortion, yes. But after delivery, we can try to remove the IUCD if still available. If not, sometimes during delivery the IUCD gets expelled. So how do we check for lost IUCD? So for lost IUCD, we do X-ray because IUCD is very visible. It is clearly visible in X-ray. We can do X-ray and see if it is inside or not. Ultrasound might miss it, especially if it has. Sometimes the IUCD perforates the uterus and goes beyond the uterus. It might go to the intestine. It might touch with the intestine. Sometimes it perforates the intestine. It might also migrate to the liver or somewhere else. So with X-ray, we can 100% be sure that there is no IUCD. Those with lost IUCD might have expelled it without knowing it. So the first thing is we do X-ray and find it. The second is X-ray. X-ray will only tell us where it is. I mean, with AP X-ray, we can only know where it is. We cannot know the depths where it is found. we can know it is in the pelvis. We cannot know whether it is inside the uterus or not. So in this case, after we can do ultrasound and confirm it is in utero, or we can do CT and MRI, then localize it and then have a surgery for removal. So, can you recommend use of Depo-Provera for more than a year and it stopped? It is associated with twin pregnancy. Okay, so Depo-Provera for more than a year, yes, we can recommend. As I mentioned before, the American College of Obstetrics says you should not be afraid to order it. The only thing is this prolonged use has two side effects. One is bone density decrement. The second one is prolonged delayed ovulation. So if a woman wants to use it more than a year, she's more than welcome. She can use it for even 10 years. It's not contraindicated. And when you stop it, it's associated with twin pregnancy. I'm not really sure with Depo, but in COC, they are associated with twin pregnancy for the first month. So when we stop COC, the first month, when you have rebound hormones, the incidence of twin is higher because the FSH will be higher. During the COC, the FSH was suppressed, it was not available there, and when you immediately stop it, there's a rebound high FSH, which will induce risk of high rate of fraternal twin. Not identical, it has no effect on identical, but it has increased risk of fraternal twinning. This is true for COC, but I haven't read for Depo. Contraception for CKD in hemodialysis patient. There's no specific contraindication for this for the hormonal ones, but those with CKD they will be less mobile. Then if they are less mobile, then the risk of the thrombosis will be higher, and the risk of COC will have higher thrombosis. So I would prefer using the copper one, the copper ICD. It is much safer for chronic disease, for most chronic disease, but specifically.
Yeah.
So there's one more question. Best recommended method after abortion for mother wanting pregnancy in short period. So after abortion, we advise women to avoid pregnancy in the first 3 months. So for this, I usually advise them to take COCs usually because it is very short, 3 months. Or if they don't like hormonals, then she can use condom. I don't like to give them Depo for only 3 months because she's planning to get pregnant.
Yeah. Thank you.
Okay. Thank you.
So, on behalf of Blueheads Ethiopia and all our participants, we would love to thank you for taking the time to present on our platform. It was indeed a very clear and amazing presentation. You have addressed all the questions in the chat box, and thank you very much. And we hope to have you in the future with other topics as well on Blueheads Ethiopia. So, Dr. Alexander, if you have anything that you want to address as last, let me give you the chance one more time.
Thank you very much. Thank you for having me. I'm also very happy to have this presentation. Thank you very much.